I'm very pleased to be able to introduce our moderator of our panel today, Laura Landy. Laura is a friend and a colleague on the board of the Fannie Ripple Foundation, which is about a $80 million foundation that was created for the purpose of providing support for women, for the elderly, for the treatment and research of heart disease, cancer, and to provide support for hospitals. And I think there's nobody better to lead this panel this morning than Laura. She is now a national speaker on the issues that we've talked about. She has been an academic, a business consultant. She's a wife, a mom, and she's a whirlwind. If you remember the old Tasmanian devil, that little whirling dervish, there is a rumor that that was a caricature of Laura Landy. When we talk about innovation, our foundation and Laura in particular have helped to lead a collaborative process nationally that is really consistent with what you've heard from other speakers this morning. That is a process that is designed to encourage a national conversation and collaboration among academics, national and state political leaders, physicians, other providers, insurers, local leaders, and consumers to provide better care, better health, lower costs at the community level. I'm pleased to introduce Laura Landy.
Thank you, Ed. I feel like I should stand up here and spin for a while. It's really an honor to be here and to kind of return to a place where I actually worked for a couple of years, and Jim's job is the interim director of the center, so it's very exciting. And really want to thank our first three speakers for really setting the stage for the panel. What I want to do is summarize a little bit about what's been said and to set up a transition to what the panel is going to talk about. We have four amazing panelists, all of whom could talk for 40, 50, 60 or more minutes themselves, and I think we'd all find it very interesting. But our hope is to do a brief introduction of the panelists, to have each of them speak for just a few minutes. We're hoping 5, 6, 7 minutes, and then create some opportunity both for dialogue and for questions and answers with the group. So I think a couple of things that I'm hearing are from these speakers, and from what I'm hearing at conferences and meetings really across the globe, is that the conversation is shifting. We know at Ripple that 45 years ago, the first president, Julius A. Ripple, in 1965, was saying that we have an unsustainable health system, and that if we're going to create a sustainable system, we have to actually figure out how to keep people well and totally redesign our health system. So 45 years later, we're having the same conversation, and what I'm hearing really for the first time is people saying, yeah, this is really real now. We're not just saying this is really happening. We have to take this seriously. And I think there are two reactions that we'll see, and in the great work that these presentations have pointed to, is that it both is creating opportunities for amazing innovation, and a lot of that driven by communications technology, medical technology. The other thing that's doing is creating competition. And I think it's important to acknowledge that and bring that into the room. For the first time, I think we're really having a sense in the medical community that not all the hospitals are going to be here 10 years from now, and not all the specialists are going to be here 10 years from now, and doctors' jobs aren't going to look the same, and nurses' roles are going to change, and there's going to be a new employment base of community health workers doing something different, and that my kids are going to be on the iPhone, and this is really going to be a different world. And how do we, as a community, as an industry, but also as a community, really own that change and manage it and lead it in a way where as few people as possible are hurt and as many people as possible are helped? And I think that's really the challenge we're all working towards. One of the other things I think is important to recognize is the importance of context in everything that we're doing. I know David Shulkin, who's going to be on our panel, the head of Morristown Memorial, has worked in New York, he's worked in Pennsylvania, he's worked in New Jersey, and talks about three very different cultures. And what works in one place we know doesn't work in another. So how do we actually start designing solutions that are flexible enough and robust enough so that they can be adapted to the local cultures and the local conditions? What's going on in Salt Lake City is terrific. It's not going to happen in New Jersey. We know in New Jersey from the data of the Dartmouth Atlas that we have the highest, we're the highest spending country in the nation. This is the highest spending state in the highest spending country. We spend more on healthcare than any other state in the nation. We consume more healthcare as individuals than any other state in the nation, and we don't have outcomes that are any better. So there's a particular challenge to New Jersey about how do we get our own healthcare house in order at a time when we're looking at opportunity costs in education, in infrastructure, in the environment across the state that are challenging us. So how do we actually do this for ourselves? I had talked a bit about the work of the foundation, which I could talk for a long time about, which I won't. But in working with some leaders across the country, people like Lynn Ostrom, who's a Nobel laureate in economics for her work on how do you create sustainable resource management. People like Don Berwick, who you know is the head of CMS and formerly head of IHI. Marshall Gans, who ran Obama's grassroots campaign and really looks at how do you motivate people for change. And Peter Senge, who's the father of the Learning Organization. These are leaders who have been transformative in actually shaping organizations and shaping action. And how do we start bringing that kind of new thinking into the health industry? The final theme before I introduce the panel that we're hearing over and over again is about the importance of collaboration and the importance of team. Medicine for a long time has been an individual business, particularly in New Jersey with these small practices. It's been about the doctor. It's now becoming about partnerships. It's becoming about collaborations. It's becoming about cross-sector collaborations in ways we've never had to consider before. I was speaking with a woman yesterday who started to talk about the cost of collaboration. It takes time, it takes effort, it takes trust, it takes engaging, it takes showing up in meetings. How do we actually start working together to create that kind of community of trust and collaboration that allows us to accomplish what we all want to accomplish, which is access, high quality care, better health for our populations, and sustainable costs that allows us to do other things with our money other than just purchase health care. So with that as a stage to set, I want to just briefly tell you who's going to be on the panel. Our first speaker will be David Shulkin, who is the president of Morristown Medical Center, comes to Morristown having done a turnaround at Beth Israel in New York. David also is an entrepreneur who started Doctor Quality, which focused much more on the consumer side, consumer education, building relationships between consumers and doctors. And I respect David for his willingness to really be a pioneer and to put his actions behind where his values are in health, and he will be our first speaker. Our second speaker is going to be Simon Samaha, who's the president and CEO of the Summit Medical Group. The Summit Medical Group has been around since 1919. I was close. I was going to say 80 years. It's 90 years. And has grown to be the largest medical practice in New Jersey. What's interesting about the Summit Medical Group is it's really taking a full view of how they engage with their consumer. How do you keep them well, from Tai Chi and acupuncture to how do I do surgery? And managing those relationships in locations across the state with a very diverse group of healthcare practitioners and multiple relationships with businesses, with individuals, with payer agencies. Judith Kutzleb is our nurse practitioner on the panel. And I'm happy to say another woman, so I'm really pleased with that. Judith is really pioneering in what is increasingly being looked at as, I believe, a forefront of how medicine is going to be practiced, which is the changing role of the nurse. And the role of the nurse practitioner practice, both in supporting doctors, but also in being a delivery vehicle in itself. She's also a faculty member here in nursing at FDU, and is working on the non-pharmaceutical edge of intervening in specific diseases like heart disease. So, we have another approach to medicine that's emerging that's really taken on quite a bit of power. And my last piece of paper is gone here. I don't do this right. And I don't have it, so here I go. And my last speaker, and I apologize, Harry, is Harry Reynolds, who is I love this title, and I think there's a reason why I'm having him go last on the panel. So Harry is the Director of Health Industry Transformation for IBM Global. And with a title like that, we would expect Harry to be able to kind of sum up the whole picture, both nationally and globally, about what's happening in health industry transformation. So, you know, we'll see what happens. But I think more seriously that the role of companies like IBM, both in their own health management practices, where we know that companies across the country are reducing their own costs of care by 20–30% by managing their populations and bringing really good health and healthcare practices into the workspace. IBM has been one of the leaders in that, as well as the leaders in technology and communications and its impact on health. So with that as an introduction, and I hope not too long an introduction, I'd like to introduce David Shulkin. I'm going to ask the panel to stay at your tables for now until David is done, and then I'm going to ask you to come up after he's finished with the slide.
Thank you very much, Laura. What motivates us all, I think, is our own life experiences and the stories. So in the next few minutes, 6 minutes in fact, I'm going to share with you a bunch of stories about what is helping to motivate me. The first story is a love story. This is Sorrel King and her daughter Josie. Josie died at Johns Hopkins University of a medical error, and Sorrel recants how many times she tried to tell the healthcare workers that her daughter was dying and they wouldn't listen to her. That motivated us at Morristown Medical Center to develop rapid response teams where family members and patients can actually call for help. We now at our children's hospital let family members round with our nurses and our doctors and include them in their care. That also motivated me to write this book, Questions Patients Need to Ask, to help patients know what questions they need to know to be safe in a hospital and to be an engaged consumer. The second story is a bedtime story. I spend a lot of my time in hospitals on nights and weekends, which are very different than daytime hospitals. That led me to write about my experiences at nights in hospitals in the New England Journal of Medicine, where I was able to talk about what happens in hospitals. And you can see mortality rates are higher, readmission rates are higher on nights and weekends, and surgical complication rates are higher on nights and weekends. That's helped lead us at Morristown Medical Center. We now have nocturnists, full-time attending physicians 24 hours a day at night to be able to help people on nights and weekends. We've increased our staffing levels, and we've paid more attention to communication challenges on nights and weekends in hospitals. The third story is a missing person story. This is Temple University Hospital, where I was the chief medical officer. And my very first patient that I admitted at Temple University Hospital was a patient with orbital cellulitis. I got a chest x-ray. The report came back, and the report read they had a big gunshot wound in their chest. And I figured I would have picked that up. What I learned was that it was the wrong patient. And I began to realize how often we get the wrong patients in hospitals. The second part of this story is, this is my medical school, the Medical College of Pennsylvania, where both my wife and I graduated. It went bankrupt. The Philadelphia Inquirer got the records out of bankruptcy court and found out that this hospital had 598 incidents of medical errors. You don't normally see this type of data, and 66 deaths due to mistakes in just a short couple-year period of time. So it began to say how unsafe hospitals are. This is a patient who was operated on at the University of Washington. This is from the New York Times. He tried to fly home at the airport and didn't make it through the metal detector because there's a 10-inch retractor still in his belly. At Morristown Medical Center now, we wand every single patient who has surgery to make sure that this can't happen, and so we're using that type of technology. The next story I want to talk about is a mystery. The most frequent phone call I get as a CEO of a hospital is from somebody saying, can you help me get an appointment with a doctor? I can't get in to see a doctor. And it's so hard. When I was in New York, we opened up our primary care practices 24 hours a day. So if you need to see a doctor or a primary care physician at 3 a.m., you can do that, and that keeps people out of emergency rooms and keeps them well. I also started a company called Open Doctors. This helps people get next day appointments. When there's open appointments and a patient wants it at 3 a.m., they can go online and they can schedule an appointment. You can do that now at Morristown Medical Center. A transparent story. We know that patients are increasingly want more information about their patients and doctors, and increasingly it's becoming easier to learn the cost and the quality of doctors and hospitals. If you walk into a Chinese hospital, right in the lobby, when you walk in, you will see billboards like this. This is every procedure they do and how much it costs in yuans. We don't do that here. That did lead me to start a company called Dr. Quality. Here we are on the cover of Modern Healthcare that helps people understand how they could select better quality and better value in healthcare. Running a New York City hospital, this is called a foreign story. We were very close to Chinatown, and learning how people wanted their care led me to take 25 Asian physicians over to China. Here I am trying to explain in Chinese the American healthcare system when I don't understand it as it is. One of the things I learned in China was that this is the president of Guangdong University and myself. After dinner, they had 2 hours of karaoke where I had to sing 1950s American show tunes, and that was quite an experience. Also about understanding people's beliefs. This is Donna Karan, again from the New York Times. Donna Karan and I took 300 of our nurses and administrative leaders and chairmen and taught them for a full day in her studio yoga and other healing culture techniques. At Morristown Medical Center and Atlantic Health, we've really built integrative medicine into the way that we practice and are building a 25,000 square foot facility down the road. This is a horror story. This was my first day at work at Beth Israel in New York City, and I walked into the hospital, and this was standing in front of the hospital. I was new to New York. I didn't know what it was. I'm sure most of you do know. This was an expression of how the workers felt about management. The union put this in front of the door. In contrast to that, this is a survey team that went down to NASA, and they were studying NASA's operations. They stopped a janitor, and they said, "What do you do here?" I thought that was a dumb question. The janitor said, "I'm helping send the man to the moon." So that's in contrast to how you have to work with your employees. At Atlantic Health, I'm fortunate to be in an environment where we really work together with our employees. We're one of the top 100 places to work. And my last story is a dirty story. This is true. This is the JFK men's bathroom, if any of you have ever been in there. Half of you haven't, I'm sure. And essentially, they had a problem. They had a problem with people missing the urinal. So they hired a bunch of consultants that came up with 4 solutions. One is hire somebody who would stand there and just watch people and say, "Hey, you're missing. You know, do better." This is true. Secondly, hire a statistician who would plot the spillage area and see, is it fat people that are doing this, short people that are doing it, tall people that are doing it? Third, why don't we just double the size of the urinal so nobody will miss? And fourth, just etch an image of a fly on the porcelain. They actually did. They etched images on the fly. This is true if you go into these urinals, and they solved the spillage problem because men are very competitive and don't miss. So that's leading me to my next project. And that is to put up a new building called the Center of Advanced Medicine on the Morristown campus, a mile away from here, which is going to have forced functions and build continuous quality improvement into the engineering of the building. So, and with that, I'll stop.
I'm going to welcome up Simon Samaha, the President and CEO of the Summit Medical Group.
Well, thank you. I have 5-6 minutes. I'll stay to them. So the organization I represent is a physician organization. It's probably one of the oldest in the country. It was founded in 1919 by 2 physicians who actually came after the war and liked the idea of working together. It was incorporated in 1929 with a mission that we, up till today, stuck to it, but now we're re-examining it. The mission is to care for the ambulatory sick. So we've never, despite the fact that the 2 physicians actually were the founders of Overlook Hospital, never extended into the hospital or the inpatient. We stuck on the outpatient. Today we're probably one of the largest in the country. We're around 230 physicians, and we offer all the services except the pediatric specialties. And you know, when I was asked to talk about innovation, you think back, and I'm not sure anything we've done deserves to be called innovation. A lot of what we're doing is really adaptation, because, and you know, a lot of the stuff that has been discussed, I wish Dr. Popiel had stayed around, because what I wanted to say, and I wish he was here, although he could not speak to the outcome of the patient-centered medical home, I think I can, because 23 of the physicians who were involved in that joined us, and what we've seen from what they've done is absolutely outstanding. So what we're doing is actually taking the model that they've done and expanding it. So what I can tell you about the innovation we're doing is the following. We're re-examining everything we do, and we're realizing, despite the fact that we were probably one of the most financially successful physician practice in the country, we don't do everything great. So we're re-examining our primary care model. We're looking at managing through disease-based. We are engaged in telehealth. But I think the other more, and again, I can't use the word innovation, but the better thing we're doing is we're looking to collaborate not only with the payers, we're going down to the broker, we're going down to the employer. So a week from now, October 19, we have a broker who actually happens to be in the room here, and 7 employers and a payer, and we're meeting with them to design them what is the health benefit program that they're interested in having, because ultimately between them and the employees, they're our customers. So we're working with them on designing a plan that works for them, and most important is we're looking through the continuity of the services literally from a supply chain and trying to focus on let's do what we do best and not do what we don't do best. So there are certain competencies as a physician practice we can do extremely well. There's some we can't. So rather than keep trying to do it, we're trying to leverage the competencies that each entity in that supply chain can offer. And the other thing we're doing is we're taking risk. So with these employers, we're basically guaranteeing them that their cost of care will be lower than it was prior year, and if not, we're actually going to foot the bill. We do have an insurance company that we're using for that, but we're guaranteeing them that their cost of care. So, you know, we took to heart the concept of care has to be cost-effective, cheaper, has to be high quality and high service, and we're putting our financial risk on it. So that's where we are today, and I appreciate your time. Thanks.
As Judith comes up, just in homage to Steve Jobs and Simon's comment about not being an innovator, I think it's really important that we recognize what innovation sometimes is. And it's sometimes the incremental improvement that actually adds up to radical change over time. So if we look at what Steve Jobs did, you know, what was it, 35 years ago, he came out with the Apple I, which was this box, you know, this wooden box with this kind of funky keyboard on it. And now we have the iPhone and the iPad, and that has been a step of incremental changes over a very short period of time that have transformed the world. So you know, as we think about innovation, it's not hatching the next total solution necessarily to all the world's problems, but it really is the hard work of day-to-day showing up and trying to do something better that can add up to a better world. So, acknowledging that. Okay, Judith Kutzlieb, nurse practitioner, head of a nurse practitioner practice, and faculty member at FDU.
Good day. Well, you've heard a lot of different things. Well, for me, I need to talk about the innovative opportunities for advanced practice nurses, especially those who are seeking and have obtained, as I have. I was the second to cross the finish line of the Doctor of Nursing program here at FDU. So in the transformation of the current healthcare system, affordable care requires the rethinking of the roles of many healthcare professionals, especially those of the nurses, because we need to meet the demands for higher quality, safer, and more accessible care, which seems to be the key thread through the whole Innovative Summit. The healthcare reform strategy has been identified is to care for the uninsured and the underinsured. Through the design of my advanced practice nurse model, the inception of the FDU faculty practice was designed. The program concept uses faculty from FDU's Henry P. Becton School of Nursing who hold certification as advanced practice nurses, and I've integrated the faculty slowly into my primary care practice, and we deliver the care to this population of underinsured and uninsured and self-pay people. So what's really the goal? The goal of my practice is to provide affordable care, medical services to people who are either uninsured, underinsured, or not offered insurance by their employer, but they have the option to choose to pay out of pocket for care. And we manage acute and chronic conditions. We do preventative screenings, and we also identify pre-existing conditions which have led to denial of health insurance coverage. So what's the innovative solution? Well, patient noncompliance, as you've heard, requires a collaborative approach in order to manage the multiple comorbid chronic disease processes people acquire over time, and to provide affordable health and accessible care, which allows and encourages patients to seek care. Because the problem that we encounter over time and continuously every day in our healthcare organizations is the numerous emergency room visits that are fragmented care. Patients are not getting continuity of care, they're getting inconsistent care, and it's very costly care. And if we can really circumvent that repetitive recidivism to an emergency room, we may provide better care. So the solution is to really try to find that primary care solution for follow-up and decrease the potential oversight of critical health issues, as well as we lead to better communication, avoiding gaps in care, and with these repeated visits, it leads to backing up and bottlenecking in the emergency room. So affordable care is really a medical necessity, and it's to promote and preserve quality of life. What does our program do? It delivers the highest level of health care to diverse members of our society. We provide full-time clinical patient management Monday through Friday to all adult individuals who are uninsured, underinsured, or self-pay. The primary care providers are advanced practice nurses. We currently service 65 to 70 patients per week with an average of 10 new patients weekly. So I currently have 1,000 patients in my clinic. We provide a full range of services that include diagnosis and treatment of acute and chronic conditions such as COPD, diabetes, hypertension, GI disturbances, depression, infections, pneumonia, injuries, and we prescribe medication and treatment and manage the total patient care. Our pharmaceutical management, the drugs are based on affordable plans because if they can't afford it, they're not going to be compliant. We meet family practice healthcare needs, including acute and chronic conditions, everything from hypertension to diabetes, and annual examinations. Our performance improvement initiatives include hypertensive management with the goal of keeping the systolic blood pressure less than 140 or diastolic blood pressures less than 90. And diabetes, our goal is to have a hemoglobin A1C less than 7, but we even minimize that even more to 6.5 to 6.8, of which we have achieved. The role of the partners, it's a collaborative educational partnership through strong commitments, not only through FDU, but I also service Touro Medical School, of which I am an affiliate faculty. We work in tandem to provide real-time clinical practice and knowledge preparedness for all levels of nursing and medical students. Through the clinical rotations, the students provide medical health, and this population is supervised by myself and my APN partners. The partnership provides increased primary health care. We promote health and disease prevention and offer the next generation of healthcare professionals a unique opportunity to witness the effectiveness of comprehensive primary care disease management. As full-time faculty, as another hat that I wear, I am the coordinator of the APN program here at FDU. My active clinical management of acute and chronic disease states enables my students to feel the pulse of a holistic integrative approach to primary care. My clinic offers these students the opportunity to develop clinical skills, critical judgment, and diagnostic testing interpretation to formulate an affordable plan of care that targets disease management. The clinical rotation enables these students to have the opportunity to work with a team of healthcare providers in a system that delivers quality care that is patient-centered, it's accessible, evidence-based, and it's also sustainable. The IOM, which promoted the future of nursing has 4 tenets. Nurses should practice to the full extent of their education and training. Nurses should achieve higher levels of education and training through an improved education system that promotes seamless academic transition. Effective workforce planning and policy making are required for better data collection and improved information infrastructure. And lastly, nurses should be full partners with physicians and other health professionals in redesigning healthcare in the United States. Thank you.
Simon and David, why don't you come up and take a seat while I introduce Harry so that we can move straight to question and answers and discussion right after Harry's presentation. Once again, let me introduce Harry Reynolds, who is the Director of Health Industry Transformation at IBM. Harry brings a very interesting history in health and technology, having worked in hospitals with payers, in corporations, with government, and has really seen many sides of the health and technology story. So I welcome Harry.
So I'm going to JFK right after this speech. I'll send you all an email on how they're doing with their study. Being an older guy, you know, I'll get a chance to check out those facilities. So traveling around the country, I'm a little more excited now about actually going there and spending a couple hours. So it should be kind of interesting. One thing you might not know about IBM is we cover over 400,000 of our employees with health care, and we spend over $1 billion a year. We care. We don't just care as a technology company, we care as a company, and I'm sure all the other companies that were here do the same. Example, one of our benefits we have for our employees is unlimited primary care visits with no copay. If you don't get them in to take care of themselves, we love the word presenteeism, not absenteeism. So just a little heads up there. Somebody asked a question about 2020. Let's talk about 3 possible ingredients in 2020. There's going to be a lot of discussions on models, and for 7 years I was on the Maine Health Policy Advisory Committee to the Secretary, 3 different secretaries of HHS. Coordinated care or integrated care, whatever you want to call it, wired health, and the patient or family caregiver engagement. The day my father died, he was seeing 7 different significant physicians, taking 41 pills, and my sister was the caregiver. I didn't say the doctor, I didn't say the hospital, my sister was the caregiver. I understand coordinated care. And as you look at it, and as you look at the things that everybody has talked about up till now, if you've gone through any of those, you understand where we got to go and how it happens, because there's an incredible number of professionals, but they don't necessarily have the information that they need to have all the time. How many of you have a GPS? How many of you would rent a car now without a GPS? Think about it. It was set up as a global positioning satellite and system to figure out certain places. It now has transformed itself. It really allows me to independently function in unknown environments and find things I want, like food, hotel, and entertainment. And it's updated at every wrong turn that I make. And it continually gets refreshed. If you have a car and you have it in there, you sometimes have to load the new software. IBM's announced something called Watson. We used it to win a Jeopardy game against the Jeopardy champions. We just put it against 6 cardiologists in the field of cardiology and barely won. It's new to the industry, but maybe Watson becomes the GPS. Now, one thing to remember about that, do you still drive the car? Yes, you do. So whether it's a GPS for caregivers or whether it's a GPS for the patient, you still drive the car. So nothing's going to care for you, nothing's going to take over the technology-wise, but it sure would nice to be happy to have something like that in your environment, especially as you're being treated by many different people. This is absolutely an exciting time. Yes, I was very much involved in health reform when I was with the Blues and others. It is a very emotional environment, and the regulations that were discussed and everything create havoc in many people's lives, and they're very much hope for others. So I'm not up here to talk about that. But the important thing is the industry is alive. And I travel coast to coast and some internationally, and I will say to you, there are people you've never heard of. You got a lot of distinguished people on this panel, and you got a lot of distinguished people in the country to talk. You ought to see the ones you don't know. They are kicking butt, taking names. There is change throughout this industry, there's change throughout this country, and you can be cared for just as well in the small places as you can in the big places. People are trying to make a difference. Now, all the challenges that everybody brought up before, absolutely. But this energy is alive, and as an American society, once we get alive, we make things happen. So there's plenty of burdens. I've been in this industry for 42 years. I know what slow is, I know what fast is, I know what right is, I know what wrong is. Now, if I knew the right answer, I'd be signing my book after, which I don't have. But I do get a chance to go around and see an awful lot of what's going on. As you really think about things like coordinated care, you talk about electronic medical records. Let me give you an example. Some of the payers, I know a payer that's spending $15 million to give doctors up to $40,000 apiece for electronic medical record systems. I know a hospital that I met with the other day that set aside $120 million to give 3,000 doctors an EMR coordinated through them. I didn't say it's right, didn't say it's wrong. I'm talking about you don't hear those things often. People are trying to play with each other, well, you know, in many different ways. Many providers that I meet with are also becoming payers. Many payers I meet with are also becoming providers. Point is, in the end, there's some kind of model in this that we all hope is going to work, and it's going to make a difference. And only if you play can you figure out if it does or doesn't. You know, so the word pilot in the past used to be something you tried. Now it's something that you continue to build on, and you continue to look at as you do it. And the monitoring is just taken off, and I think it's great. Having implemented e-prescribing in North Carolina, I'm clearly aware of how important it is to incorporate the pharmacy and all the aspects about drugs in. If somebody doesn't pick up their medication, let's get an idea what might be their care. It's going to get worse. If they can't afford it, how do we get it to them? If they live alone, how do we deliver it to them free? Those are the kind of things that as you go around the country and hear about it. And then consumerism. How do we get people to engage? I have a sister that's obese. I can't get her to engage. So you can set up all these things you want to do. If my sister doesn't engage, she's in trouble. And she will remain in trouble for a long time. How do we get individuals to engage? Really, really engage and make a difference. And then the idea of extreme personalization, and we're seeing an awful lot of that. You heard that a lot from the gentleman that talked about medications, but extreme personalization. Saw an application, very simple application the other day that somebody was doing. They have an iPhone. They were using it on an iPhone. Every field you enter has its own keyboard. How many of you have wanted to enter a phone number and you had to trip around alternate and you had to find all the letters, get away from the letters? Which one is it, top or bottom? No, just the letters came up. Extreme personalization to make sure the right things happen. Analytics is going to be huge, and you've already heard a lot about that. Access to care, the whole retail thing, I'm seeing dramatically. Many people want to see their docs at night. I heard the 24-hour clinic. On the other hand, what if you went into Walmart to a clinic, and oh, by the way, that clinic was staffed by one of these hospitals up here, so you recognized it when you went in. And oh, by the way, if they can't see you in 10 minutes, they'll give you a buzzer code so you can go do your life services. And then if they don't see you in 30 minutes, they'll give you a $10 store coupon. Game on. It's on everywhere. No, the answer's not clear, but the point is we're getting to see it all day, every day, and it is really exciting, but there are plenty of hurdles. So thank you very much.
So we're going to invite questions from the audience, and also if anybody on the panel has questions for the other panelists, we invite that as well, and you can direct it to any individual or to the panel as a whole, and we'll see who jumps up and answers.
Hello. I think it was wonderful, all the speakers, and I'm really looking for information. And one of the questions that was not answered for me is, what about alternative medicine? And how does that phase in with the planning for changes in healthcare?
Well, I don't have any great insights on this, so I hope Simon does. But you know, 30% of the healthcare dollar is spent in non-traditional ways, and so I think that the old approach of the traditional healthcare community ignoring that and ignoring the fact that our patients come in and are taking lots of supplements and not sharing that with us is a mistake. So what I think the more progressive systems are doing, and I think Simon's group is one of them, and my institution is one of them, we've now begun to offer a integrated approach. So whether a patient wants Eastern or Western philosophy towards medicine or a combination of both, we're able to provide that. And so, as I said, we're building a 25,000 square foot facility on South Street in Morristown to expand our capabilities, and we're seeing a huge demand for those services.
We don't have a separation between alternative. We actually call it integrative medicine. And for example, in our spine center, the acupuncturist is part of the team. As a matter of fact, I went to see her yesterday, and she just pulled my record because I play too much golf. I have a back problem, and she pulled my record. And so they're integrated. We don't separate them, and it's part of what you know, the patients, the consumer, everybody wants to use. So we have them in an integrated model. We don't like the separation. You know, you go here if you want this, and you go here if you want that.
And from my perspective as an educator, I do teach alternative options to my students, because not every person that comes to seek medical care is going to want a pill. So we also have to recognize the need for alternative medicine, and I do refer to acupuncturists and alternative treatment options for my population. In my clinic, I'm also responsible to manage the Korean population, which is a very, very difficult population to manage as an American, to try to integrate their mindset, their values, their beliefs with their health.
Yeah, having been with a payer for a number of years, as long as the three of them would agree to take care of the person, make sure that the outcomes are good, the cost is right, and so on, I don't think you're going to see the payers in the future caring exactly what they do include or not include in those benefits.
And I think hearing what the panel is saying, that this is really pointing to this sort of new model of integration that, 10 years ago we wouldn't have had the same conversation. And the same kind of conversation now is also happening with public health and health for the first time. Is, can we actually get in the room together and figure out how we do an integrated system? So there's a lot of breaking down of some of those traditional barriers that we've seen in the past to actually find what works and what will keep people healthy and what will give them the best care.
I kind of think the elephant in the room, too, is geography. As I work with the patient community, that we were talking about New Jersey, or we're talking about different places where patients can be treated, but with mobile health, I wonder, aren't they going to be treated where they can find the best doctors? And who will pay for that? And I think the man from IBM touched on that a little bit, of what's coming. But I know with the cystic fibrosis community that the best doctors from MAC might be in Denver. Everybody wants to go there. They want to move there. But with mobile health, maybe they don't have to move there.
I was meeting with a prominent hospital group the other day that the doctor does most of his rounds virtually. Okay? His statement, I thought was excellent, was there are no borders once you get into certain diseases. Now, you need to have people on hand. You need to have people that are caring for them, and you need to have somebody that's got their overall care. But to call in other people, how many of you Skype? I Skype from my grandson all the time. Some of these other things that are out there, these are technologies that, again, we haven't necessarily addressed in the environment. What does it cost to Skype? So the point becomes, we all worry about cost. If that's a reasonable type of a care, and these three people are taking care of the person, and they decide to bring that person in, whether it's their person sitting there that they have in their own institution or it's somewhere else. The technology will not be the issue there. It will be how people have agreed to do coordinated care, and what does coordinated care? Is it in your state, in your region, or in the country? Or globally. Or globally, excuse me. And so that's what I'm seeing. And again, I'm not a doctor, and I didn't stay in a Holiday Inn, so I'm not trying to take over their care. But I can tell you there is plenty of technology, there's plenty of innovation out there, but it has to be the model, and whether it fits their model, and the three of them can decide that is the right model for this particular situations, and then how do they deliver it.
we're applying it specifically in telehealth. I'll take your comment and stretch it a little bit. Medical tourism, it's today a $10 billion industry, and last I checked, inbound to the US is much lower than outbound. So today the biggest, actually 5 years ago, if you would ask what's the biggest center for prostate surgery, it would be at Hopkins. It's no longer there. I believe it's in Kuala Lumpur. Mayo Clinic is in Dubai. I was in Dubai a year ago, and their perspective is, why should we go anywhere to get our health care? We want the best health care to come here. So, you know, on top of the technology, there is a much, much more active medical tourism that is building. I was at a conference with a team from India. They have reduced the variable cost of open heart surgery to $1,500. I worked with hospitals, and I can guarantee you, either of us would love to see the ability to go down there. And a lot of it had to do with how they streamlined the care team, where literally it's becoming almost an automated individual managing the flow of patients. $1,500, and now their next goal is to actually go below $1,000. So, you know, if you're going to shell out of your pocket $50,000 to get a procedure, and you can get it if it's an elective procedure, I can tell you there are a lot of people. We're seeing a lot of people actually coming back from South America for procedures, cosmetic, plastic, and you know, obviously we see those who didn't work, but that tells you that there's a lot of people going, and you know, again, last I checked, the study was that the outbound outside the U.S. is now bigger than the inbound.
So David, a question for you. The impact on hospitals, on your hospital in particular, of medical tourism or the Mayo Clinic offering telemedicine, you know, as the best in the world. How do you think about that and think about the future of your hospital and other hospitals in this changing environment?
You know, I mostly, I think that the medical tourism component is a interesting tidbit, but I don't think it's real. It's not that there aren't thousands of people doing it, but I don't think it's a mega trend that we have to focus on. I think that these are more, you know, there are some high visibility companies like Hannaford Foods in New Hampshire that have, you know, offered to have their employees have their hip transplants in the and all that, but I think that they were more making statements. I think people want their healthcare local. I think that we have to respond to the challenge to lower the costs and to provide the type of coordinated care here, but that's where people want it. I mean, you all know you can go and you can buy your cars cheaper if you go to Europe and bring them back. I mean, people aren't going to do that in mass numbers, I don't believe. Now, whether teletechnology is going to fundamentally change the model of how we deliver health care, that's been promised for a long time. Again, I'm not betting that's going to fundamentally change things. I think people want a physical person to be taking care of them that they can communicate with. But if we ignore all these trends, I think it will definitely happen because we are going to make this an unaffordable system.
Thank you. Let's take another question.
My question is more around consumer accountability and responsibility. And so I'd like to understand from each of you, who do you think is ultimately responsible? And Simon, to your point, you talked about the patient-centered medical home and the success that you're seeing at Summit Medical Group. So I'd like you to discuss that in a little bit more detail. And Harry, you talked about how you motivate people to change, you know, patients at the center. So I'd like you to talk about that as well.
With two payers, we're working on a model which is technically an opt-in. So we're putting together a product. It's highly customized, but you have, as a patient, you'll have to opt into it, and part of your opt-in is a consent for care management. I think that the comments that David made on medical tourism is absolutely true. If you consider medical tourism across borders, there is, I can tell you, and this is a problem for us because as we're getting engaged in, you know, committing to decreasing cost of care, when we look into utilization, there's a significant percentage of our patients are actually going to New York, they're going to Pennsylvania, and they're getting their health care there. You know, I don't see a reason why they need to, I mean, obviously people have choice, but there is migration across states, and that's not insignificant. I can tell you, when we saw the data, we were surprised how large it was. I mean, just to give you some perspective, the majority of our care is at Overlook. Most of our physicians actually don't go anywhere else. So we assume that 90+% of our care is there. We're actually finding out that it is much less than 90%. So what we're doing with these two payers is to set up an opt-in. We're also exploring options with mobile apps so we can communicate. Part of the problem is also that, and you know, myself included, people don't understand their benefit. So we're trying to create an environment with them where we have much more communication with them. We've recently, with the Paramount Group joining us, the material we sent to each patient who belonged to them was actually personalized to them. You know, hello, Mr. Smith. And it was literally based on your age, what your personal need. I think this is going to become a bigger problem as your out-of-pocket goes up. Today there's a mindset that, you know, I can go shop around, I can, you know, it's the insurance company is paying or the employer is paying. I think these will drive. But, you know, you're going to have points where, you know, you can't engage, and I don't know that there's a silver bullet. I'm happy that, you know, there's a recognition that moving one step at a time is also a part of innovation, because I agree with what Dr. Popiel said. This is not going to happen where one day we wake up and we've got the magical word. It's one step at a time.
Judith, they're hearing.
You guys go ahead.
I think it's a partnership between the provider and the recipient, and I truly believe that patients are accountable to their own health care, and they need to be educated on it. I have written numerous patient education pamphlets that are individualized to the patient and the reason for their acquisition of their disease process. There's a lot of information in there that's targeted toward understanding their disease, but my thesis and the underlying mantra to my approach to patients is to keep them in the driver's seat. Do not let the disease put them in the passenger seat. Once that occurs, they've lost control. And as long as you keep the patient in the driver's seat with teach-back methods, the ability to understand how to manage their disease, they can have a quality of life, do the things that they like to do. Once those aspects are usurped from an individual, their motivation tends to you know, slack off. And, you know, that precipitates failure in a trajectory of, you know, increased cost of care.
Any last words?
Yeah, I think as you look at it, there's kind of three different degrees. There's the healthy. How do you keep the healthy healthy? And I travel a lot, so if you're not in a fitness center in a hotel by 6:01, come back at 7:30. The healthy motivated are there by 6:01. You can count on it. So that's one segment. The other segment is the chronic, and you heard the discussions today. 50% of the people are going to be in those categories. How do we? What are both the benefits and the care capabilities that are out there? So, you know, you hear a lot about home health, and home health was only given in certain situations. Maybe, depending upon who you are, what you are, and what you are, the benefits are adjusted immediately to you, not adjusted to the whole population. And as I was speaking to CDC and the Medicaid directors, this idea of, you know, a lot of the government programs have very, you know, kind of singular type benefits. But as soon as you are a severe diabetic, as soon as you are a severe asthmatic and other things, certain things kick in. Reason is, if they don't, and we don't engage the person, and we don't get the person to engage, then I promise it's an ugly journey. And then you get the middle where the information seekers, which is, you know, a lot of them come in and they've already diagnosed themselves, because face it all the time. They look out at the information, but they don't necessarily how to know. Now, how do you get them involved? And then, as I debate around the country and the world on health reform, you got to go to culture. And we get real emotional in the United States about you know, we're not going to let somebody have this and we're going to let somebody have that. On the other hand, we got to get people have to engage, and that's a real cultural issue in this country, because no matter what benefits you give them, sometimes they don't come. And if they don't come, what then do you do? You know, do they get a free pass, or do you do something? So again, I'm talking to you as an industry person. That's not an IBM position.
Questions? We've got time for just a few more.
Each of you brought good insight and talked about your experiences in many different ways. Love the idea of hearing the anecdotes about the fly in the toilet, and certainly hearing about the work that you're doing and bringing care to patients before they get to the emergency room. On the topic of keeping healthcare costs down and making the healthcare system more efficient, I'd like to get your insight on what we could do going forward from a collaborative standpoint. I think each of us comes to this conference. We all have different roles, whether it be in the pharmaceutical industry or responsible for actual healthcare offices, et cetera. But many times what happens is we're all trying to create an individual solution, right? And I would argue that the solution to the problem of rising costs and inefficient care is already, perhaps even in this room. It's that in many cases just the individual motivation and bravado, et cetera, makes us want to come up with our own solution. But perhaps what any one of you is doing in your own microcosms could be the solution for all of us. I'm very interested in what your call to action for us might be in that idea of trying to reduce the cost of healthcare and make the overall system that much more efficient.
I think that's a fabulous question, an appropriate question to end the panel on. And I'm going to ask each of the panelists to answer the question. What would be the call to action? What could everybody do? And you're asking specifically collaboratively to actually move us ahead towards reducing costs and improving health and improving the quality of care. Whoever wants to start. I'm not going to put anybody on the spot.
I'll throw myself under the bus. President Clinton once said, "It's the economy, stupid." Healthcare is a sickness economy, not a health economy. And I think the first thing we have to do the solution is not in simplistic ways. I think the solution is much bigger. I think the first step we need to make a decision: is healthcare a social right, or is it a market? Because we treat it both ways. In France, if you go there, they'll tell you healthcare is a social right. Everybody's entitled to it, and they deal with it. I think we've been very schizophrenic whether healthcare is a social right. The second thing, we need to accept that if we need to drive the cost down, there have to be losers and winners. And you can't motivate innovation or any of this stuff if the perspective is everybody's going to lose a little bit. So I don't see how you can eliminate cost if every player in healthcare, payer, provider, broker, name them, they all have to be preserved. They make the same margins. I don't know how you're going to do that. So I think your call to action is, a lot of it specifically in the state of New Jersey, start with the state behavior, where you have entities that really don't need to exist, and they are causing inefficiencies. I wish if there's an economist in the room that will challenge me. My belief that healthcare is a supply more than a demand. Build them and they'll come. So when you have excess players that have protection from being eliminated out of the market, good luck. You're not going to decrease anything. So we're going to be chipping around, and we're going to play a little bit, but I don't know how this is going to change without bold actions.
David, you want to jump in?
Well, I think Simon was dead on target, and I'm not ambivalent about what the solutions are. I just don't know that I'm right. But what I would say is that New Jersey is by far the most broken state I've ever seen. There is no hope for us to get healthcare costs down unless we tackle some of the issues that Simon's talking about. Hospitals need to close, and capacity needs to decrease. Instead, we're seeing the opposite. We're seeing actually hospitals that have closed about to reopen. We are seeing an unregulated environment where doctors own their own facilities, their own imaging facilities, their own surgery centers, and they're keeping them busy. My answer is that we need to have more integrated delivery systems. That means that the doctors and the hospitals and the payers and long-term care need to be integrated into an economic unit, and then, as Simon was saying, make the economic incentives something different than fee-for-service. Make them based upon the value that you want to get out of them, and I think that that's how we'll reduce healthcare. Now, am I optimistic in New Jersey? Not particularly, because this is a state that has avoided what other states have learned over decades.
Ruth, I'm sorry, Judith, you want to go? Or?
Go ahead.
No, I just think that healthcare has become a very reactive theme, and we really need to be a much more proactive organization as healthcare providers. I think primary prevention really is the key to the future, instead of secondary and tertiary prevention, which is, okay, now we've got the disease, now we have to just marshal our forces to halt this disease from progressing, which is essentially a losing battle if we haven't been up front initially.
I'll break it into the three categories I talked about earlier: coordinated care, and so IBM put their money where their mouth was. Unlimited primary care visits, and we just redid our health insurance, and if you didn't have a medical home in the state you're in, you don't get to have our insurance.
And what did your premiums go up last year?
Limited, very limited.
Very limited?
Very limited.
So it's
we've been managed, it's working.
Good.
So I'm just saying to you, so as a company, are you demanding that you're going to let your employees get care, and that you're going to require that the care be given in a coordinated way? Now, it's still infancy on medical home, but if you couldn't talk it and you didn't have it and you weren't heading that way, you didn't get our business. Okay, so that's one. Wired health, we talked about. Are you going somewhere where your information is shared amongst all the people that are taking care of you? Guess what? Each of us, I have a grandchild, and my entire goal is to change the world for him. Mm-hmm. And so each of you have kids and grandkids. You got to get in, and you got to make sure that you're not just doing what you were doing. You're not just going through a niche environment. You're making sure that you're getting involved. So that's the most fun part of my job. Everybody I pass today, we're trying to help. That's pretty fun as you go around. Daunting, but pretty fun. So I think, and then the patient and family engagement. How do you get, I know, for example, if a hospital where my mother and father had very difficult deaths would have said to me that whenever the doctor came in, they would let us telephonically talk to the doctor when we were out of state, I guarantee you, they'd have gone to that hospital every single solitary time because we were out of state. This isn't magic and mystic, a lot of it. It's called, are you caring for the person? Are you really coordinated? Yes, the money has to flow the right way, and again, I've been on all sides of that. But you really got to go get it, and you got to care, and you can't just say, well, healthcare is not mine. Same thing for Medicare, same thing for Medicaid, and I'm telling you, Medicare and Medicaid are going to be talking medical homes just as much as I just did, by a multiplier. So if you put FEP, Medicaid, and Medicare behind some of these words, game on in a different way.
So let me pose something that picks up on this theme, and I really appreciate the directness of the panel. I think this is a important conversation. It's a conversation at that level of directness that we don't have in New Jersey enough. You know, as they're saying, New Jersey is more challenged in many ways than any other state in the country. And IBM not only is putting their money where their values are, they're also making plant location decisions based on what the healthcare is in a country, and have recently decided to move to somewhere in the Midwest. I don't remember where.
Yeah.
Because
it was Iowa and 3,000 employees.
Because the healthcare costs there were $4,000 or $5,000 less per person than in other places in the country. So this is a big deal, and it's a serious deal. Now what can we do collaboratively? You know, looking just at New Jersey, I think we've got to start having the conversation. The leadership is in this room to make a difference. You know, if we don't have a shared vision of what health in New Jersey should be, we don't have a plan. There's no, David and I have talked about this, there's no strategic plan for how we really deliver affordable care to the populations across New Jersey. And we have a changing population. It's a big deal. The state is not providing leadership. So how do we cultivate the leadership ourselves to actually create the political will and the social will to actually do what we need to do for our state, not only for our population and for our healthcare system, but also for our industries and, you know, for our future. So, you know, could we, as a group in this room, take on that challenge of working together in some way, and maybe Jim and I can talk about that, of actually starting it with a vision, looking at some of the alternative futures that are ahead of us, talking about the hard questions that we're afraid to ask, doing this as a public conversation, engaging our politicians, engaging our healthcare leaders, drawing on the expertise of IBM and others who have been out there doing this in their own companies and creating models. And let's see what we can do. I think the potential is here, the power is in this room, the challenge is huge before us, more so than any place else in the country. And if we don't take hold of it, the external forces are going to start taking control. And we may or may not like what the outcome is. So with that parting word, I want to thank our panel. I think they've been fabulous. And
thank you.